Alrighty, everybody. Welcome to this week's EKG review. This is our EKG, so let's go ahead and take a look. So, first step I always do is I just kind of look at the trees. And so if I look down here at my lead 2 rhythm strip, I see I've got some QRSs. Okay, there's this pause, QRS, pause. Kind of some maybe group beating, but there's not really a set pattern to it. I see that my QRSs appear to be wide. If I zoom in, say on this here in AVL, I would say these QRSs maybe are 160 milliseconds. So wide. We know that wide QRSs can be caused by um, things that cause the ventricles to be depolarized, not through the typical His-Purkinje highway system. So that's just kind of my first start here. What is going on with this EKG? We've got a wide complex QRS. We've got a decent rate. The rate seems to be 300, 150, 175. This would be 60, so maybe 65 beats per minute-ish until we have these pauses, obviously. So there seems to be maybe some type of block going on. We know that group beating, we think of AV node blocks, but let's take a look, see what we get. And so I look and I see P waves. So let's look at our atrial activity. I see P waves before the QRSs, and I see P waves before these dropped QRSs. P wave, QRS, P wave, drop. Same thing here, drop. And those P waves appear to be upright in lead 1 and upright in AVF. And so I can say from that, this is a sinus P wave. Okay. And let's take a look at the AV node's function. And I see that our AV node is our PR interval, and the PR interval actually looks decent. It's less than 200 milliseconds, which is normal. And it stays that way throughout. I'm not seeing the PR interval change. And we're looking through, and as I look through these other leads, what I want you to notice is interesting. Before this QRS, I see this little spike. I see this spike right here in V3. Interesting. And I even see it maybe up here in V1. You see that little spike just before this QRS. You can even see it up here in lead 1. There's a little spike just before the QRS. And so, is this a paced rhythm? I don't see spikes before the P waves, so the atria is a normal depolarization, but that would make sense, this wide complex tachycardia, or wide complex rhythm. And let's take a look at the QRS. The QRS is wide, and in the inferior leads, which are 2, 3, and AVF, it's a negative QRS. And so negative QRSs in the inferior leads mean that the axis of the QRS is going from inferior to superior, which would make sense because pacemaker leads are typically in the inferior portion of the ventricles, right? And so I can say, yeah, this is a V-paced rhythm, okay? And you can see those pacemaker spikes really nice here in V4, V5, V6. You can't always see them in every lead, and that just depends on which leads capture this pacemaker spikes the best. So this is a spike. Okay, so we know that this person has a pacemaker. So what is going on with this rhythm? Why are we having beats that are being dropped down here? Well, you could look at this and say, maybe it's because there's no pacemaker spike there. Is the pacemaker not firing? Is the pacemaker not firing versus is it not capturing? Not capturing would mean that there is a spike, but no ventricular depolarization, right? And so let's take a look and see. So if I look at AVR for this dropped beat, we see our P wave, and I see a pacing spike just there, but there's no QRS. And if I look over here in V1, I see a P wave, I see a pacing spike, but I see no QRS. And typically you'd see the pacing spike and then your QRS. If I look at V4, I see my P wave, I see my pacing spike, and no QRS. P wave, pacing spike. In the ventricles, as we can see by the pacemaker spike that's occurring nicely timed after this atrial contraction, this P wave, right? It's just happening about maybe 140 milliseconds after that P wave, which is exactly when it should, right? It times itself. It's sensing in the atria, and it's timing that ventricular spike accordingly, but it's not capturing. And so what we can say is these dropped beats all throughout are caused by failure to capture. And so let's take a look at what that means. So this person has a dual chamber pacemaker, and the way I know that is because even though we're only pacing in the ventricles, say this is my pacemaker, and the pacemaker has two leads, one of them that comes through down into the right ventricle, and another one that comes and it sits in the right atria. And so there's a bunch of different modes that this pacemaker can run on. But in this case, remember our EKG, we had normal P waves, okay? So the sinus node, what that correlates to is the sinus node here it fired off and caused the atria to depolarize. And when it depolarized, this atrial lead sensed it, and because of that, it was inhibited. It doesn't need to fire. And so what happens is the pacemaker, it registers that P wave, and then it begins a clock or a timer. And that clock or timer is set to be what a typical PR interval would be. And so maybe in this case, it's maybe 140 milliseconds. And so the ventricular pacemaker lead that's down here is waiting. It is waiting 140 milliseconds, and it's saying, okay, if I get ventricular depolarization and I sense it here, I don't need to beat. But if I don't sense it in 140 milliseconds, then I'm going to beat. And so in this individual, 140 milliseconds goes by. This pacemaker lead says, okay, I need to contract the ventricles. Since the atria contracted just a little bit ago, it fires. And if it captures the ventricles, it is going to depolarize inferior to superior. It is going to be a wide QRS because it's not using our His-Purkinje system. And so that's how you know that this person is, the current mode that they're in is atrial sensed ventricle paced. And that is the mode that we see this individual in, because if you look back at their QRSs, you've got these pacemaker spikes that are occurring. We'll look at V5. We've got these pacemaker spikes that are occurring right before a Y complex QRS, but we have normal P wave. And so this person is having a failure to capture, and what that means is that when this pacemaker is firing, it is not firing to the point where it captures ventricular depolarization. So not capturing equals need to turn up the voltage of pacing spike. And so if we can turn up the amount of electricity that is being sent into that ventricle, then we would be able to capture in these areas where we're failing to capture. And so in this case, it's not that we are not firing the ventricles, it is that we are firing and we're not capturing. And based on the pattern, we can tell what part of that pacemaker is dysfunctional. We know that our PR intervals have been normal this whole time. So we know that it's sensing in the atria, it's sensing in the ventricle, and it's sending these pacemaker spikes in the ventricles right after these sensed P waves, but we're failing to capture. And this person needs their electrophysiologist to help them out. So hope that helps. Have a good day.